Hello and welcome to the third annual ENIGMA IPV in Pink Concussions IPV Brain Injury Conference, Empowering Innovation, highlighting promising practices in intimate partner violence and brain injury research, recognition, and response. My name is Carrie Esopenko, and I'm an associate professor and co-director of the Traumatic Brain Injury and Concussion Center at the University of Utah, as well as a part-time associate professor at the Icahn School of Medicine at Mount Sinai in New York City. I lead the ENIGMA IPV working group, which seeks to support and expand global research on IPV-related brain injury. ENIGMA IPV, in collaboration with Catherine Snedeker from Pink Concussions, co-developed this conference with immense help from our conference organizing committee. In our first year, we set out to provide a free and easily accessible venue to provide research and practice-based information to partners on IPV-related brain injury. In our first year, we saw over 500 people register, with many also viewing the recorded sessions online after the conference ended. In our second and third years, we have built on that initial momentum with almost 700 people registering for the conference each year. Again, this year, we are excited to see a broad representation of registrants globally, as well as representation across many community, advocate, and provider roles. I'd like you to take a moment to complete our pre-conference survey. We developed this survey so we have an understanding of who is attending the sessions. So if you could scan the QR code or use the link that is now in the webinar chat to complete the survey, we would greatly appreciate that. I'd also like to acknowledge the conference committee who worked tirelessly to develop a program that addressed suggestions from last year's attendees and to advance our mission of providing a thorough overview of current research and practice-based information for IPV-related brain injury. I'd also like to do a special shout out to Ella and Maddie, who really worked tirelessly to make this day happen, or these 2 days happen. And we're the ones who have really taken the lead in organizing this for us. And so we are eternally grateful to their help. As a committee, we would also like to share our conference mission. As the organizing committee, we are cognizant of the biases that exist in clinical practice and research, and thus have endeavored to include a broad group of speakers representing a range of understudied topics and work that incorporates underserved communities. We have worked to increase the accessibility of the conference by providing a free, virtual, and recorded environment. As well, we also acknowledge that our work spans many First Nations, Inuit, and other Indigenous territories, moving forward in a way that promotes anti-racism and anti-colonialism. We are committed to educating ourselves and understanding the truth of our shared history with Indigenous people. And some housekeeping as we move forward in these next 2 days that are filled with amazing speakers. Please ask any of the questions you have in the Q&A box. We will work to look at all of the questions and ask our speakers at the end of their talks. You can exit and join the Zoom as you'd like. We do have around 700 people that have registered for the conference, and the webinar currently has a max of 500 people. Although we don't anticipate filling that at all times, if you have a moment where you cannot come on because we are full, please just try again. But with the global representation, we assume that people will be coming in and out and we won't hit capacity. But if we do, please again, try to come on at a later time. However, we have the sessions will be recorded and they will be hosted on YouTube in the next couple of months. So if you miss any sessions or you aren't able to access at that moment, we will have these sessions all available to you in the later date. We also want to give a content warning. Given that the prevalence of IPV, we recognize that the content of this presentation and related discussion may be triggering for some attendees. If you would like support or after or during this presentation, please feel free to reach out. We do have supports in place if you have any stuff that you need to discuss during the webinar. So again, please reach out. Also, feel free to log off from the webinar and rejoin at a later time or mute the speakers as needed. So let's talk about intimate partner violence. So what is intimate partner violence? Well, intimate partner violence is a behavior by an intimate partner or dating partner that causes physical, sexual, or psychological harm, including physical aggression, sexual coercion, psychological abuse, and controlling behaviors. And we know that the global burden of intimate partner violence is profound, that many individuals across the globe are impacted by IPV, and it is estimated that around 1 in 3 women over the age of 15 have experienced intimate partner violence in their lifetime. We also know that IPV is most prevalent in women 18 to 24 years of age, and that more than 80% of Indigenous women in the United States have experienced intimate partner violence, stalking, or sexual violence. We also know that women of color and women with disabilities experience higher rates of IPV. And the Center for Disease Control estimates that around 33% of women report physical aggression from an intimate partner in their lifetimes. And yes, both men and women experience IPV. However, violence against women tends to result in more severe and more chronic injuries. But since physical and sexual IPV often includes injuries to the face and head, as well as strangulation, suffocation, or other forms of impeded breathing, there is a high risk of experiencing brain injury. So let's take a moment to talk about the prevalence of IPV-related brain injury. There have been a number of review studies that suggest that anywhere between 27 to 100% of women who are exposed to physical IPV report trauma to the head, face, and neck. And that seems like a big range, and the 100% seems a bit strange to see. But what the 100% represents is studies that are recruiting people that have experienced physical violence to the head or face or neck. So the incidence of brain injury is around 100% in those specific populations. But even at that lowest range of 27%, that's a very extreme high number of people who are experiencing physical IPV that are experiencing brain injury. And when we look closer at these studies, we're seeing that around 50% of individuals in these studies report multiple impacts with exposure to head trauma, and others are reporting so many exposures that they can't even count them. And it's estimated that around 23 million women are living with IPV-related head trauma in the United States. And so let's take a moment just to talk about the current definitions of traumatic brain injury. And when we look at the Veteran Affairs or the Department of Defense definition, which we use a lot in the United States, what it states is that it includes damage to the brain or how it works caused by a blow or force of the head. And this is usually caused by an external force, such as being struck by an object, an impact without a direct hit, a penetrating injury, or a blast or explosion. And this can result in a loss or alteration in consciousness, memory loss for events before and after the injury, as well as confusion, disorientation, slower thinking, sensory loss, and changes in balance or vision. And then when we look at the American Congress Rehabilitation Medicine mild traumatic brain injury definition, what it states is that mild traumatic brain injury results from a transfer of energy to the brain from an external force causing the brain to move within the skull. And this can be caused by being hit by something, hits hard, or when your head hits a hard surface and moves around quickly, or a blast or explosion. And for diagnosis of a mild traumatic brain injury, you need to have at least one clinical sign present. So something like loss or alteration of consciousness for less than 30 minutes, memory loss, and it has to be attributable to an injury. Any injury that is greater than 30 minutes or any loss of consciousness that lasts for longer than 30 minutes is not classified as mild and would be something in the moderate to severe range. There also needs to be two acute symptoms, at least two acute symptoms. So things like memory loss, confusion, headache, or nausea. And if there is positive imaging or abnormalities on CT scan or an MRI, that's more likely in the complex mild TBI component. However, these definitions do not specifically include near fatal strangulation as a mechanism of injury. And thus, many non-fatal strangulations or near fatal strangulation related injuries that result in neurological signs and symptoms may be missed and not clinically characterized. And with the new National Institute of Neurological Disorders and Strokes classification of TBI, They've updated their framework, which will actually help us classify IPV related brain injury better. And so the updated framework includes 4 pillars. We have a clinical pillar, which includes the Glasgow Coma Scale, as well as the added pupillary reactivity score, as well as some expanded clinical outcomes. They've added a biomarker pillar, which includes blood-based measures, like blood-based biomarkers, and they suggest that these should be included or collected in individuals acutely, as well as an imaging pillar, which includes a CT scan or an MRI. And we know that there's a better availability of CTs acutely and use of MRI for chronic and persisting symptoms. And now the new framework for TBI includes reference to sequences that now also measure hypoxic injury more directly. But within this new framework from NINDS, we also see this modifier pillar. And this includes psychosocial and environmental modifiers that incorporates 3 classes of basic components, such as injury-related factors, patient-related factors, and community and society-related factors. And this specifically includes collection of information about exposure to hypoxic or near-fatal strangulation events, as well as perceived life threat and reported or suspected non-accidental injury by another person. And this new classification provides a more comprehensive classification of TBI and now also accounts for violence-related injuries, which we hope will result in a better classification and management strategies. And this is extremely important as we think IPV represents a distinct brain injury phenotype. So when we look at the mechanisms of injury within episodes of abuse or in IPV, we have individuals that can be punched, kicked, or hit, or slammed into something. And this can result in a focal injury to the brain. We also have individuals reporting that they've been shaken violently, pushed, or shoved, and this can result in diffuse injuries to the brain. And then within these episodes of abuse, we also see these happening together. So we have individuals who are reporting being punched or shaken violently, resulting in both focal and diffuse injuries. And then we also have to consider non-fatal or near-fatal strangulation, suffocation, or other forms of impeded breathing, which result in an anoxic, hypoxic, or hypoxic ischemic injury. And again, this is also co-occurring with these other forms of abuse, meaning these individuals are experiencing all 3 of these at the same time. And not only can they experience all of these mechanisms of injury at the same time and have these exposures in the same episode of abuse, but what we're also saying is that these repetitive exposure to injuries can be occurring over the course of months to years. And however, with the older classifications, many of these individuals were not being, or many of these injuries were going undetected or undiagnosed. And thankfully, over the past number of years, we have been doing a lot of research to try and understand the effects of these injuries on individuals. And I'm excited that for the next 2 days, we hope to increase that knowledge base. And with that, I'm excited to introduce the speakers for the conference. It will run today and tomorrow from 10 until 6 Eastern time, where we'll have a mix of practice-based and research-based speakers. Today, we will start off with our practice-based keynote, Maria Wilburn, and tomorrow we will have our research-based keynote, Dr. Paul von Dogler. We will also have plenty of research and practice-based speakers throughout the day, so please tune in. And of course, like usual, we are very excited to highlight the work of our trainees. These individuals are the ones that are taking the torch from us and making sure that this work carries on. And so we're so excited to support them and to hear all about their incredible work. And again, like last year, we will also have sessions from our survivors. So we have 2 sessions planned. The first one is a survivor-based conversations. We'll have 2 individuals having conversations with myself. And tomorrow we have a survivor panel, which will be led by Catherine Schnedeker from Pink Concussions. And so please tune in if you can't. Again, if you cannot make the sessions, they will be recorded and we will post them at a later time. And again, if you have not already, please do the pre-conference survey. This really helps us understand who's attending the conference and helps us plan for next year. So with that, I'm so excited to launch the conference and I hope that you enjoy the next 2 days.